Good. My next panelist is Kamala Malik-Kane as a research associate in the Justice Policy Center at the Urban Institute.
Okay, thank you, Ben and Cochs and the National Council for inviting me here today. What I want to share with you today is some work that Urban did in collaboration with the IJIS Institute and Bureau of Justice Assistance. And this was a stakeholder working group that BJA had convened in order to identify opportunities for information exchange across the full spectrum of the justice system and the full range of different health provider types. And so we facilitated a working group process over a course of about 6 months where we identified 34 different information exchange possibilities that are both aspirational yet realistic across the full spectrum. And so what I want to share with you are some of those findings in that process and some of the overarching information needs that these exchanges can help to fill. But just very briefly, I wanted to go over what some of the potential benefits of this information sharing are. I think we're all here familiar, but I just wanted to lay a groundwork. Most important is really this need to improve outcomes for people that are shared clients of both the health and the justice systems. We know that this is a population that has a high level of healthcare needs, be it physical health care, mental health, or addiction. And this population receives very fragmented care as they bounce back and forth between these two settings. So continuity of care is a really huge issue for this population. But this also leads to some needs to bring about greater efficiencies. In being seen by these two different settings, this population is assessed and asked similar questions in multiple settings, leading to some redundancies and perhaps some ability to get better information from particular sources to feed the process in the right place. And on top of that, automation of information exchange can lead to better data security and sharing what is sensitive information, better timeliness and better accuracy, which is really crucial if you want to generate a system where you're exchanging sensitive health information and things that have a real impact on patient safety, like prescription drugs and dosages. So with these goals in mind, BJA convened a stakeholder working group of health and justice policymakers and practitioners. The goal was to brainstorm opportunities and be expansive for thinking through all of the various intercepts between the justice system and health providers. And so this is a very broad framing of justice, beginning with initial encounters with the police, through to the pretrial and court stages, incarceration in jails and prisons, as well as community corrections, including probation, parole, and the reentry process. The conception of health was similarly broad, encompassing medical and pharmaceutical needs, mental health, substance abuse, as well as many different provider types like doctors, clinics, hospitals, labs, public health agencies, and also insurers. And so through this stakeholder working group process, we identified 34 opportunities for information exchange. And this was an aspirational list of things, but also realistic in the sense that the data are available and collected by these agencies, but with some real obstacles, that the data might not be electronic, and definitely issues to work out around issues of consent, permission and authorization to use the data, and also cost, of course. So for each of these information exchanges, our process developed what IT folks like to call user stories and, in some cases, use cases to really specify the type of information that's to be shared, the timing of when the exchange should happen, the direction and the flow of the information, whether that goes from justice to health, or health to justice, or as a bidirectional exchange, and the specific challenges that need to be overcome for that exchange. So I'm not going to talk through all 34 exchanges with you, but I wanted to address what the 4 major information needs these exchanges pretty naturally grouped into. I'll just list them out first and then get into a little more detail about some examples of each of these. So the first sharing need is assessing an unknown situation so that you can respond appropriately. The second was to determine placement and program eligibility. The third, and what the group felt was the most important for the field to move forward, is collaborating on care between the two systems to facilitate continuity of care. And then the fourth was monitoring client progress and compliance under supervision. So I'll go into a little more detail about each of these. And one thing I do want to note is that most of these are exchanges that involve the exchange of health data, but there were other types of information that the stakeholders felt were useful, so things that are generated by the justice system that may not be as sensitive as health information are still valuable pieces of information to exchange. So with assessing an unknown situation, this is something that happens in both justice and health contexts. It could be a person being arrested, a person who's being booked into a detention center, or somebody showing up at an emergency department. And in all of these cases, the personnel who are working with them don't really know who they are or what their needs are, but they have to respond quickly in order to make a decision and to do what they need to do to keep this person safe. And in this case, information sharing is something that can help to fill that gap quickly and to help to develop an appropriate response. The second place where information sharing can help is in determining placement and program eligibility. And again, this is something that's a need both on the justice and health sides. On the justice side is a need to gather as much information as possible to make decisions about diversion programs, whether that's either a pre-booking diversion or a diversion that's something like a drug court or a mental health court. And on the health side, programs also need information from justice. So one of the big considerations that I've heard in working with programs is this person violent? Is there a risk of violence? And that's definitely something that goes into the decision-making on a community provider about whether they're going to accept this individual to work with. The third and the most important type of information exchange that our stakeholder group spent some time thinking about was information exchange that facilitates continuity of care. And that's needed on both the justice sides and the health sides. From a justice perspective, having access to community medical and mental health records really makes a difference in terms of being able to continue the treatment being offered to a person on the outside. And on the health provider side, having correctional health records is part of building the bridge to a reentry connection and facilitating continuity of care once somebody leaves corrections so that there's less fragmentation in the care that individuals receive. Finally, we also talked about information exchange to monitor individuals who are under community supervision. And here there are a lot of possibilities to increase efficiency and reduce redundancies. So one of the possibilities the working group discussed was sharing drug testing results. So if somebody is on community supervision and being drug tested as part of their probation, why replicate that in the treatment setting if there can be information exchange about those results that feed back to the treatment setting? And on the other side, if a person is in a treatment program and under justice supervision, then probation might need to know about whether this person is attending as expected. The other information need that we heard from the treatment provider side of things really had to do with some justice information that could help their clients be successful. So transmitting information like court dates would help a treatment provider to help to ensure that clients are making their court dates and not failing to appear. And there was also a need expressed to know if somebody is incarcerated or arrested, so then the treatment program can know where their clients are and they can take the next steps in order to try and facilitate some continuity with the correctional health system that now has their client. So most of these exchanges obviously involved sharing health data. And the key issues here to work out were client consent and legal permission to use the data. Our group was more involved in identifying issues than solving them because we weren't dealing with one particular jurisdiction. But the essence was that you have HIPAA protections on personal health information. If it's mental health or substance use data, there's additional federal regulation in CFR 42 Part 2. You also have state and local laws that are governing the use of the information. And the real takeaway here was just the upfront work that was needed to get stakeholders together to determine each party in the information exchanges HIPAA status as a covered entity, and to just to get a handle on what the relevant laws were and figure out what permissions would be needed in order to share data, and whether that means developing a consent process on the justice side or the health side or both, so that information can be exchanged, that there are consent documents to allow this to happen. The working group also discussed technological solutions to separate out shareable and non-shareable data. IT experts talk about data segmentation as a process to tag each piece of information with its privacy requirements, consent requirements, and sharing properties. Of course, none of this is cheap to do, which brings us into the next major challenge, of course, which is cost. The complexity of determining what these sharing parameters are and developing the right interagency agreements and the infrastructure to make exchanges possible. Then the challenge of making information electronically available, and one of the real promises is the CCBHCs is this requirement to collect data in electronic format, so that becomes a way of doing business. And then of course, is the investment of time needed to set up the information exchanges and the learning curves needed so that staff can use it and be successful with it. In the end, the working group felt that strong leadership was really vital to make all of this come together, that you needed somebody with vision and dedication to champion these causes and commit resources to see them through. It's exciting to see the field move in this direction. Providers and stakeholders will have a challenging transition to undergo before these gains in efficiency can be seen, but once implemented, there's such potential to really improve public health and public safety outcomes.